Good afternoon or good evening, everyone. Welcome, come on in. I am Nicole Swiner, and we'll do more formal intros in a moment, but we're just kind of letting folks in the room. Gonna start the Twitter chat, all that good stuff. Thank you for joining us. Looking forward to this conversation, and myself as a primary care physician taking advantage of the time I have with these two well-renowned specialists. We get to have a one-on-one conversation about pulmonary artery hypertension and all the things we need to know. So glad to have you guys here with us.
Yes, Dr. Swiner, thank you. We are now live on Twitter, so we can get going.
Hello, everyone. I am Dr. Nicole Swiner, coming to you live from Durham, North Carolina. Thanks for joining us for this, hopefully to be a lively conversation and discussion about pulmonary artery hypertension. Just as a brief intro, I am here with the France Foundation, and I have two of my wonderful colleagues and specialists who are going to be talking with us today about pulmonary hypertension and what we need to know about emerging treatments, about how all of the specialists together and primary care folks can work together to treat our patients better. My background is as a co-owner of a private family practice here in Durham, North Carolina for the past 13 years. I also serve as an adjunct professor for the UNC Chapel Hill Family Medicine Department for the last decade or so. So that's been wonderful to help stay in touch with students and learners. So hopefully we have folks out there that are continuing to learn and want to learn more about how to take better care of our patients. I have with me two of my esteemed colleagues, Dr. Highland and Dr. Chaisson, who's going to help run through a case study with us and just kind of illustrate and illuminate some things that are up and coming, that are needed for us to better understand how to take care of our folks on the outpatient side or on the primary care side. So I'm going to allow Dr. Highland to go ahead and introduce herself and tell us what she's excited to teach us today.
Thank you so much, Nicole. And I'm excited to be here as well, talking about one of my favorite topics, which is pulmonary hypertension. I'm both a pulmonary critical care physician and a rheumatologist at the Cleveland Clinic in Cleveland, Ohio, and I run the rheumatic lung disease program. Pulmonary hypertension is something that patients with autoimmune disease are at risk for, and that's why I'm particularly interested in this topic. And I have the pleasure of working with Dr. Neal Chaisson. Neal. Neal, you're on mute.
Sorry. Now that we got that bug out of the way, thanks, Kristin, and thanks, Nicole. And it's a pleasure to work with both of you today and to talk about this topic. Nicole, I'll go ahead and start with the case. So the case I thought would be fun to talk about today, just to kind of give some context to the discussion, is a patient of mine who I met probably about 6 or 7 years ago, a young woman, 36-year-old woman who had really no significant past medical history, and in fact actually was a pretty high-level athlete. She was doing CrossFit. She had done a marathon about 15 months before I met her, and she came initially to the doctor because she got concerned after she started realizing she couldn't keep up with her colleagues running, which was not something that she was known for. She had excelled throughout her athletic career, and all of a sudden was getting to the point where during her workouts, she was getting a lot more tired, a lot more dyspneic with things that were fairly routine. Eventually, running up hills was almost impossible. And within a couple of months of seeing me, she started having problems even with short runs. Primary care physician very astutely thought, gosh, there might be something cardiac going on here, sent her for an echo, and lo and behold, the echo showed a dilated right ventricle, which prompted her to be referred to a pulmonary hypertension center where we did a right heart cath here. And that was where I met her. Her right heart catheterization was pretty shocking, to put it mildly, for her, and especially with somebody with no past medical history. She had a right atrial pressure, which was mildly elevated at 8 millimeters of mercury. PA pressure which the mean was markedly elevated at 62 millimeters of mercury. She had a normal wedge pressure. And when I say that, her wedge was 10. Normally, we want to make sure that it's less than about 15. And then her cardiac output was really low. She was in right heart failure. Her cardiac output at the time was 2.2 liters a minute, which is, not something that's consistent with an athlete, right? Pulmonary vascular resistance was extremely high at 23 Wood units. And if you think about that, we're looking, normal pulmonary vascular resistance is about 1 Wood unit. She had a battery of additional testing for left ventricular dysfunction, pulmonary disease, rheumatic disease, chronic thromboembolic pulmonary hypertension, and all of that was unremarkable. And so the story kind of unfolds when we diagnosed her with pulmonary arterial hypertension.
Good. I probably have a handful of patients that I treat alongside specialists that have PAH. And so I don't get to see a lot of these medicines that we will use for treatment once a patient is diagnosed. But in general, what are the various, different types of classes that we use to treat these patients with? And Dr. Highland, we can start with you.
Sure. We currently have 3 different groups of medications that we rely on when we're treating patients with pulmonary arterial hypertension. We have, and we're fortunate to have these drugs because prior to 1996, there were no therapies for pulmonary arterial hypertension. And now we have multiple therapies. We have 3 pathways. The first pathway is the endothelium pathway. Patients with pulmonary arterial hypertension have too much endothelium, and so we can block the endothelium receptor. And we have 3 oral agents that can block the endothelium receptor. And then we have the nitric oxide pathway. Patients with pulmonary arterial hypertension don't have enough nitric oxide, and we can augment that pathway with phosphodiesterase type 5 inhibitors, which we may know as sildenafil and tadalafil, and they dilate blood vessels in the lungs just like other places. And we can augment, we have a soluble guanylate cyclase stimulator that augments cyclic GMP, which nitric oxide acts on. And so, and that's an oral agent as well. And then we have the prostacyclin pathway, and patients with pulmonary arterial hypertension don't have enough prostacyclin. We can augment that pathway with prostanoids as well as a drug that acts on that receptor. And we can give those drugs orally. We can inhale them, intravenous, continuous infusion, or a subcutaneous infusion. So we have a lot of opportunities to mix and match these drugs, and it often, which drugs we pick has to do with how sick or not sick our patient is.
Got you. Dr. Chaisson, particularly from a primary care standpoint, as we are kind of the quote, the front line for folks for most of our patients, where we kind of gather all the information, gather all the medicines, make them make sense, et cetera. What's important for us to know in terms of what to look out for, monitor for, as far as side effects or interactions and things of that nature? What, adverse things should we be looking out for on these patients' behalf?
Yeah, that's a great question, Nicole. And I'll tell you that there are things that we call expected effects. I hesitate to use the word side effects because they're actually things that we anticipate. In fact, when Kristin was talking about the prostacyclin pathway, a few of those drugs actually we titrate up until the patient literally can't tolerate the expected effects. And then we back down a tiny bit, and that is their sort of titrated dose. And so it's important from the patient's perspective and also the primary care physician or the local pulmonologist perspective, not to sort of support that and help with the therapy. So some of the things that are very typical with the endothelin receptor antagonist pathway, very common to get nasal congestion, right? And that can send you down all kinds of rabbit holes. Unfortunately, there's not a lot of great proven therapy. We often will have people either take nasal saline or a decongestant of some type or a nasal steroid. They work variably, but often patients will say that they're very congested from that pathway. Other things that we think about with the nitric oxide in the prostacyclin pathway, which we expect to happen, is frequent headaches. Sometimes people will get some joint pains, especially in their jaw, their knees, their ankles. We see that not uncommonly. We can treat that with, if there's no kidney disease, with some anti-inflammatory drugs or Tylenol. Sometimes opioids can be used. We don't try to go to those as a first-line therapy, but we can use those in severe cases. What I have found in my personal experience is that those headaches and the joint pains typically occur when you're titrating drugs, and they tend to fade off over time. I don't know what you've found. Is that what you have seen in your practice, Kristin?
Absolutely. And I was actually going to make that comment that we let patients know, at least I do, that starting the medication is the hardest part, and that their body will adjust to being on these vasodilators. All of a sudden you take a vasodilator, you feel flushed and you can't breathe through your nose, and you have a headache and you have some nausea. But if you can just tough it out for a little while, those symptoms tend to go away, and then you start to feel better. You can breathe better, and so it's all worth it.
Yeah.
And when I'm thinking about how to manage these side effects, I keep in the back of my brain that if it's bad for systemic hypertension, it's bad for pulmonary arterial hypertension too. So those class of agents that we avoid in our patients with hypertension, I tend to avoid in my patients with pulmonary arterial hypertension. Another big side effect is acid reflux. That's really common. And with the PDE5s in particular, we have to worry about sudden vision or hearing loss. That's quite rare, but that is a side effect with those drugs. So I always, bring that up and, advise my patients to communicate with their primary care or, their PH specialist right away.
And just to be clear for everybody, if you have vision changes, that is not something we want to tough out. That is a definite thing.
Gotcha.
The last one I was going to mention is diarrhea. Lots of people end up with diarrhea or loose stools. Using over-the-counter antidiarrheal is perfectly reasonable in that case, and people tend to manage quite well. As I said, over time these things tend to resolve, or at least people figure out how to manage with the antidiarrheals.
One other set of side effects is when we don't quite get the diagnosis right, or if the patient has comorbidities. Sometimes the patients, like most diseases, forget to read the textbook, and so they may look exactly like pulmonary arterial hypertension, but maybe they have some concomitant diastolic dysfunction too, or maybe they have some interstitial lung disease or some COPD in the background. And sometimes in that setting, these PAH medications can make patients feel worse, and they can have worse lower extremity edema, or they can have worse oxygenation. And if that happens, that's really worth a kind of a whole, let's reevaluate what's going on and see if these medications are even, the right medications to be on. And sometimes we actually have to pull back a little bit.
Got you. That's interesting to note that, GERD and diarrhea can be common side effects, because, we see that all the time and think it's either diet or some GI virus and all that. So that's good to know that we need to be looking out for that too. So once these patients start these medications, how do you measure their improvement or their disease progression? How do you keep an eye on those things? We'll start with Dr. Highland.
Okay. So one of the key points is that patients do have to be carefully monitored, because these patients can be fragile. So I typically see my patients at least every 3 months, sometimes more frequently than that. I usually get some measurements to tell me how the right ventricular function is doing. So the NT-proBNP or BNP is a great biomarker. I get a follow-up echocardiogram every 3 to 6 to 12 months, depending on the severity of my patient's illness. I like to assess their functional capacity, and I usually do that in the office with a 6-minute walk test. my patients call it their 6-mile walk, but it's really only 6 minutes. And also I do an assessment like the New York Heart Association functional class, where I try to see, what level activity is causing them symptoms, and assign them a class where 1, they can do everything they want, they have no symptoms. 4, they're kind of confined to a wheelchair, or they're symptomatic at rest, and 2 and 3 are kind of gradations in between. So those are the things I do at almost every visit. Then periodically I repeat a right heart catheterization. What about you, Neal? What's the frequency of your assessments?
So I will say I do the same things. And actually, Dr. Swiner, if one thing I think actually that's super helpful from the primary care or home pulmonologist end is, a lot of times patients will come and they'll say, hey, I just got some labs checked, and they very appropriately bring their labs, or they'll pull them up on their iPhone. And we almost every time I see a patient, actually, I would say every time I see a patient, we get an NT-proBNP or a BNP, and that's guideline driven, both in the 2019 CHEST guidelines, the ERS, ESC guidelines from 2015, and the more recent 2019 World Symposium on PAH guidelines. So if I could say, hey, what could we do to ally ourselves better? You guys are always going to get labs, but I think from that standpoint, if you said, hey, I'm going to just add this NT-proBNP on, in that way, when these labs get shipped over to the specialist, we don't have to actually draw more blood. It comes with it. And that's one thing I think, if we could improve patients, the quality of the experience, that's the one thing I would love to do with more people, is figure out how to get that one lab. And I go, yay, we got them all. We don't have to stick you again, And so I think that that's one thing, if I could say that would be really helpful, that'd be great.
Are there any risk calculators that are available for, monitoring patients' improvement and how they're doing on their medicines?
This is a great question, and I'm going to tell you that this is an area of much discussion, and we've made great progress even in the last 5 years. So there are multiple calculators that currently exist, and to be honest, it doesn't really, or there's no evidence that we're aware of, although I would say that's a controversial, I'm about to make a controversial statement depending on who you ask. But I think that the consensus is that there's probably no true calculator that is the best calculator. They're done in different groups. They're done in different regions of the world. And so I think you have to decide which one best matches your patient population.
I think.
Go ahead.
Sorry, Neal. I think the point is, and Neal was probably going to make this point, but I'll steal his thunder, is to pick a risk calculator.
Yep.
And to use it, that it needs to be a multidimensional approach, not just one data point in making a decision, but a decision based on multiple data points. And there is data that when physicians kind of do this in their head without going through the exercise of using the calculator, they don't do as well. And if we are not achieving, getting our patient to the lowest risk status for mortality as possible, we are not doing them a service. So using a risk calculator will help us treat to goal.
I liken it to the flight checklist, right? Is, most pilots who've been flying for many years probably have the flight checklist memorized, but they still go through the flight checklist because they don't want to crash, right? And we probably have a lot of this stuff in the back of our mind. We've been doing it for a while, but the reality is it's like that flight checklist. It just makes you think twice about, did I think about the labs? Did I think about the walk? Did I think about the parameters of the echo, their age, etc.? And when that happens, you're forced in a way to have a better assessment of what the patient's clinical status and risk of progression of their PAH actually is.
Good. A lot of my job, particularly as a primary care physician, is to talk a lot about lifestyle, diet, exercise, activity. What types of things can we make sure to talk to these patients about in terms of improving their PAH with lifestyle change.
Such a huge opportunity for aligning with as a team here. I think a couple of things, which I'll just mention, and then I'm going to ask Kristin to kind of fill in some areas where I may have forgotten. But a lot of these medications have significant side effects in pregnancy. And so we spend a lot of time counseling patients on effective birth control, making sure that they understand the risks of pregnancy. That's something where primary care physicians and local physicians can really team up to make sure that they're able to see their local health provider or OBGYN or whoever they need to see to get appropriate birth control. Other things, exercise. So we can't emphasize enough that exercise is actually beneficial in these patients. It is not detrimental. In fact, actually, it has a therapeutic effect that is akin to a medication in and of itself. And so we want to be making sure we do our part to get these people to physical therapy, rehab, and regular exercise on a local level. Kristin, what other things do we have?
Low sodium diet.
Yes.
You know, I tell my patients, as well as I'm sure you do, Nicole, anything in a bag, a box, a can, anything pre-processed, anything you don't cook yourself, and anything that tastes good has salt in it. If it tastes good, you just got to spit it out. But I really, you know, hone in on that. Keep your sodium under 2,000 milligrams a day. Read the labels. It's really almost a job within itself to keep the sodium out of your diet, and to weigh daily, because you know, if your weight's going up, that's a sign that you may have gotten into some sodium, which is, you know, puts an extra stress on the right ventricle. So sodium is bad.
Yep, you're right. The stuff that tastes good generally is not good for you, unfortunately. As always, or as usual with any of our patients, you know, taking care of their general health is a team effort. And I know that there are PH centers of excellence that are in existence. And I didn't know about this until I started talking to you guys about this topic. But, you know, what's the rationale for the existence of these centers, and how do we, as, you know, providers on the outside, get our patients involved or get involved with this type of multidisciplinary approach to their treatment? Dr. Chaisson.
Well, this is great. And I think, you know, if I we come from a PH center of excellence, so I'm not trying to toot our own horn, but I think that when you have a disease that is ultimately terminal, now with all these medicines, we have not cured the disease. All we've done is extend the lifespan of patients who have it, but we have not figured out how to actually make patients get better. We've prevented them from getting worse as quickly. But even in that context, right, it is essential to have multidisciplinary teams that are already in place so that we don't lose time, or that we don't have ineffective treatment or delays in treatment. And all of these things tend to be very coordinated, even though the treatment has largely been relegated to pills with a few exceptions. If you think about all of the people that are involved, cardiology, pulmonology, interventional radiology, sometimes surgeons in the case of chronic thromboembolic pulmonary hypertension, genetics teams, transplant people, rheumatologists, yes, of course, how could I forget those people? You know, psychiatry, these are big teams. And when they're in place, what happens is that you don't lose time getting these people, and you have people who have dealt with this before. That is reassuring. And I think if I was a patient, that's something I would want to walk into, something where that is already set. The other thing too is that we can coordinate their medication approval. You know, on average, before we were able to automate our systems, the average time between application and approval was 2 to 3 weeks. We have that down now to less than 1 day for coordination of approval. And you know, these medicines, some of these medicines are hundreds of thousands of dollars a year. And so you can bet that insurance companies are going to be pretty picky about these things. You want to make sure that you're at a place where people understand how to work through these processes, or else you're going to end up getting denied time and time again. Kristin, what are some other things I may have left out?
I'd just like to point out the pulmonary arterial hypertension is, you know, it's a very rare disease. And so, consequently, it's not something that's emphasized when you go to medical school or do your residency. And it matters, you know, there's pulmonary hypertension, and then there's pulmonary arterial hypertension, which is just one subsegment of the whole, picture of pulmonary hypertension. And if you don't get the diagnosis quite right, treating these patients with pulmonary arterial hypertension patients can actually have adverse outcomes. So that's not to say that, there are experts in the community on pulmonary arterial hypertension. You don't have to go to a huge medical center like the Cleveland Clinic, but what you need to do is see someone with a true expertise and passion in this disease, because these patients are complicated, and some of the tests that we need to make the proper diagnosis are difficult to perform correctly. In fact, at the Cleveland Clinic, where we have 10 billion cardiologists, I really only like 2 cardiologists to do my right heart catheterization, because it's a little bit tricky sometimes. And so it's, for all the reasons that Neal said, it's ideal if your patient can get at least one consultation by a true expert in pulmonary arterial hypertension. And often when the patient lives at a distance from a center, we're very comfortable collaborating with primary care physicians or their local pulmonologist or whomever, and working together as a team to help, to have you guys be our eyes and ears so that we can help our patient, and we can even employ telemedicine and things like that.
But let me make one additional plug, because I think as much as this is an important factor on the outpatient side, it's actually even more important on the inpatient side, and especially in patients who are on either medications that, if you miss a dose, require retitration, or IV medicines, or some of the inhaled prostacyclin therapies. And the reason is because these medications are expensive. They are not commonly carried on the hospital formulary. In this situation, I can tell you that the number one problem that I should speak for myself, but I have had is patients going to another hospital, and then what happens is somebody who just, not out of malice, but because they haven't had training on these pumps or these inhalers, accidentally get the dosing incorrect or the mixing incorrect on the medication, or the patient goes to the hospital without their medication because they came in an ambulance, and now all of a sudden they're stuck in a situation where they're not able to be treated with their medication because it's not at the hospital. That poses some problems. And so when you're thinking as a primary care physician or as a local pulmonologist, that should be part of the discussion. Hey, if you get sick, where are you going to go to the hospital, or where are we going to try to get you if you live far away from a PH center of excellence? And that place should have the capability to understand. And sometimes that's, you can't get around that, but the patient needs to be counseled to say, have a go bag. If I have to call the ambulance, I got a bag by the door with extra medication, et cetera, et cetera.
Very good. Very
Yeah.
good. I'm definitely going to take these tidbits along with me when I return to clinic tomorrow, and try to remember as much as I can. But I know I can always, email you guys or send you a message or tweet or whatever, just to kind of refresh my memory as far as things that we should look out for. I know we're coming down to the end of our chat, and I was just kind of checking back and seeing if we have any questions in the chat or the Q&A. Don't want to miss if anything, if anyone has any comments or questions. But just as we kind of wrap up the session, Dr. Chaisson, Dr. Highland, do you want to let folks know, your final thoughts in terms of this topic?
Yeah, we need our primary care providers to help us with all the other parts of our patient. Our patients still need their cholesterol checked, and their mammograms, and their pap smears, and all this, and all their vaccinations, and all the stuff that you guys are so good at taking care of. We're simple lung doctors, and we're counting on you to take care of, the rest of our patients. So we need you.
Absolutely.
Yeah, I think that the best cared for patients are the ones where there's an open line of communication, because my sister is a primary care provider, and I'll tell you, for as much as I could take care of somebody who is extraordinarily ill in an ICU or with pulmonary hypertension, I call her all the time for the things that are normal primary care problems. And I think what that suggests to me and what I've recognized is that everybody has their niche. And in good patient care, we put those together. And I think it's about us understanding what you guys do well and you understanding what we can work with. And then the best part about this is when we pick up the phone and talk to each other.
Absolutely.
Yeah. So thanks for inviting us, Dr. Swiner.
Thanks to the France Foundation for inviting me
Yes.
to meet you guys. Thank you so much for helping us understand this a little bit more. I think we're good to go. I don't think we had any, at least, outright questions or Q&A things right now. I think this recording will be available so folks can go back and look into it or look at it and hopefully add, questions or comments, or maybe even contact us through the France Foundation, or we can leave our info so people can get in touch with us. I'm being sent a message that attendees will be emailed a link for their evaluation as well. So let us know how much we helped you to understand this a little bit better. And I think that's it. Any other
Great.
thoughts? I think we're good.
Thank you
Thanks.
so
Have a
much,
wonderful
Nicole, for
afternoon.
hosting us.
Thank you so much for the info. Thanks for everybody for listening and paying attention, and be safe out there. Get your COVID shots.
Yes.
Ditto.